Live now. Uh, Good afternoon, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's series, a dynamic dialogue on fertility. And today's topic is different FET protocol, organized by Foxy Society Chennai and A4 Hospitals and Fertility Center Chennai. So it's my privilege to introduce the moderator of today's webinar, Dr. Aruna Ashok ma'am. Ma'am is the fertility consultant and clinical director at A4 Fertility Center and Hospital. Ma'am has more than 17 plus years of experience and mentor for Fellowship Reproductive Medicine, A4 Fertility Center from 2022 onwards, faculty of FNB Reproductive Medicine, executive committee member of TAPISAR and OXY. I welcome you, ma'am, and I hand over the session to you. Aruna, ma'am.
I think ma'am's, yeah.
I just lost contact for a minute. Now I'm yeah. Sahiti?
Yes, ma'am. I have introduced you, ma'am.
Yeah, you can show me the slide of Dr. Sachin Kulkarni.
Sure, ma'am.
Yeah, I'm very honored to have our esteemed speaker, Dr. Sachin Kulkarni. She's a Chief Fertility Consultant at Sunand and Jahangir Hospital Fertility Pune, New Leaf Fertility Clinic, Addis Ababa, Ethiopia. Oh, I'm very curious to know about Ethiopia also, sir. Sunanda IVF Academy is a fertility training academy conducting courses in reproductive medicine. Many of you who are attending these sessions would have already been knowing him very well for his academic knowledge and new innovations that he does in this field. He is published Indian Diet and Phenotype of PCOS in India was published in Fertility Sterility in August 2019, one of the important landmark study. So today we have Dr. Sachin Kulkarni on talking on different FET protocols. So this definitely has to be talked again and again because there are lots of changes over the time. Initially, we were doing fresh embryo transfer. Now we are going for frozen embryo transfer. It was 100% HRT for most of them. Now we are shifting towards natural cycle HRT. So let us see what a speaker is doing in his practice. And definitely there'll be lots of practical tips. So do follow it in your practice also. Over to you, sir, for the session.
Thank you so much and good afternoon, everybody. Let me just share my screen.
And if the session is exhaustive and you need not cut short the presentation, we can even extend it next week, sir, the same time.
Yeah.
So kindly go ahead within your own pace. Thank you.
Thank you so much. Thank you so much for that because when I looked at it, I thought this could be. Is my screen visible?
Yes, we are able to see.
Okay. Sorry, because when I looked at the presentation, I thought it could go a little exhaustive and then we may take a break in between. Well, thank you so much, first of all, for all of you and the managing committee and the Dr. Aruna Madam, especially for placing this invitation to me to speak on frozen embryo transfer cycles. I perfectly agree to you, Dr. Madam, that we went to an HRT cycle very commonly, and now we realize the importance of doing natural cycle transfers, and we are changing our policies towards natural cycle transfers. And so the problem between the two of HRT and natural cycle being the flexibility. And in a very big corporate unit or somebody is visiting many places, one is more tending towards doing an HRT, which is simple, patient-friendly, more doctor-friendly. You can schedule it the way you want it. And natural cycle the scheduling becomes a big issue. So one of the important things which I want to address in natural cycle frozen thaw embryo transfer here today is, can we make it flexible and practice it more and more? So let me just start off. Am I audible and my slides are seen? I'm just cross-checking once more.
Yes, sir, you are audible.
Yeah, thank you so much. So the freezing fever of IVF had started a decade back. And initially, I come from an era, I started IVF in 2000. So I come from an era which was all fresh transfers, all cleavage stage transfers. And I've really witnessed the whole gamut of IVF practice evolving. And the freeze over last decade, definitely we are seeing a lot of freeze-all cycles being performed. And we are all very happy about that because there is no OHSS. It's more of a friendly care. We can do PGTA more often, embryo pooling cycles, random start, onco-fertility. There's so many other indications for which we are doing freezing cycles. Somebody like me also thinks that we should not be doing fresh embryo transfer at all. But well, that's a separate topic by itself, and we can definitely discuss and debate at some other time. So freeze-all came like a backdoor entry, and it basically was introduced to avoid OHSS. And that's how the freeze-all cycles came in. And now it has become the mainstream of our practice. It has completely shifted the goals for us. And now we no more discuss much about the hormonal variations which take place in a stimulation of our control ovarian stimulation, but rather we talk more about the hormonal manipulations or the hormonal levels and cutoffs, etc., on a frozen thaw embryo transfer cycle. So what is a typical natural cycle FET? And that is typically the client would come to you on day 2, day 3 of the cycle. You would just do a scan. If on scan, if all the follicles are less than 10 millimeter, both the ovaries are quiet, you have an endometrium which is thin, less than 5 millimeter, I wouldn't do progesterone or estrogen. Also, I will just continue. Sometimes you may have a residual cyst, and then you want to know whether the residual follicle is having any hormonal activity, especially progesterone. Even if it is a small amount of estrogen, wouldn't matter much. So I would do a progesterone level and confirm that it is less than 1, and then just keep waiting. So naturally, I'll just wait. I'll ask for the cycle duration, start calling her on day 9 or day 10. At every visit, when she comes subsequently, we'll be doing a scan of the endometrial thickness, look at the dominant follicle, and we'll also do hormonal tests like LH, estradiol, and progesterone. Or we can do a stimulated cycle. We will dissect this little further. I'm just giving a small brief here. Our stimulated cycle is all known to all of you that we typically stimulate with letrozole. Sometimes I do stimulate my women who are little resistant or obese, not just with letrozole, but also by adding 2 injections of HMG. One HMG injection I give on day 3 and one on day 7. I don't give HMG continuously from day 3 to day 7. So what happens here is your letrozole is going to take your FSH level up. HMG adds on to that FSH level. So FSH level goes up little sizably up, and you can have a good follicle being stimulated. And the HMG on day 7 also prolongs the support of the follicle which is there. So in want of a better follicular health, I do this, especially for patients who could be little resistant or obese, especially that way. And again, we call them on day 9, day 10. Story is the same, that you look at the endometrium, look at estrogen level, progesterone level, and LH, and take a decision to go either with a HCG injection or to wait for a natural rupture and go ahead and transfer the embryos. But I generally prefer giving HCG injections. So programmed artificial endometrial preparation with sequential estrogen and progesterone is very easy, flexible, doctor-friendly, but the perinatal complications are very, very high, like hypertension, abortions, they are pretty high. Placental insufficiencies are high, and that's why from the perinatal point of view, this is something we should avoid doing as many HRT cycles as possible. Programmed FET are undergoing a continuous changes. It's like a backdoor entry, this whole programmed FET came in. But now we are seeing so many changes which are taking place, because the moment we started evaluating the FET cycle hormonally, we found that, well, in spite of you doing progesterone, there is a low progesterone level on the day of embryo transfer. And many of these studies were done on vaginal progesterone alone. We do agree that vaginal progesterone alone definitely increases the endometrial progesterone level, but does not make much difference to the serum progesterone level. It is not as good as that of the intramuscular progesterone, where the serum progesterone levels also could be going very high. But in spite of using vaginal progesterone, Elena Labata did a nice study when they used vaginal progesterone as a support with a number of about 1,150 cases, and they reported when the progesterone level is less than 8.8 nanogram, their odds ratio was less and they had a reduced pregnancy rate. So she said that a certain amount of progesterone is necessary to have a successful HRT cycle. So if one needs to prove a particular progesterone level can be achieved with a 40% success rate, an ideal study, a sample size would be about 1,600 patients need to be randomized, and no such study has been published. I'll be focusing on 2 studies which are under trial now, and collectively they are matching to 1,600 patients. but unfortunately their methods are a bit different again. We'll come to that at a later part of the presentation. So basically, we are treating infertile women, but they are otherwise very healthy ovulatory women. A lot of them are healthy ovulatory women, irrespective of their low AMH or their obesity. They could be just ovulatory women. And then we are treating, when we want to do an HRT cycle, we are treating them with down regulations, giving artificial estrogen progesterone cycles for an embryo transfer. So by doing a programmed FET, we are actually disrupting a well-known physiologic process of implantation and pregnancy without an apparent medical need. And that this is one thing which means you must understand. We should not fall in love with any therapy as such, especially not with HRT. Moment your love towards HRT comes down, probably you start exploring more options, and then you are sinking yourself with the physiologic process of implantation, and obviously your pregnancy rates and your live birth rate will go up, your miscarriages will come down, and parental outcomes will be better. So, as we stand today, should we be doing any patient on artificial cycle at all? So the next paper, should any use of artificial cycle regimen for FET in women capable of ovulation be abandoned? And if yes, then what should be the next FET cycle practice? And let's go in this format. I definitely agree with this paper. Yes, we must. It is a need of the hour. We should come out of HRT cycles as much as possible, unless we are forced to do an HRT cycle in some patients of thin endometrium, in a few patients wherein probably you would require in adenomyosis patients, or you are compulsorily down-regulating for the sake of adenomyosis or junctional zone problems, or sometimes myometrial cysts and endometriosis, etc. For thin endometrium also, it's not, I wouldn't go HRT today, but as the evidence stands today, we'll also visit that again. So FET regimen, you all know about, that is either you can go with the ovulatory cycle, you can go with a natural cycle, give HCG or don't give HCG, or anovulatory cycle, you can even put an stimulation to that and go ahead. But the question is, the moment you think of doing natural cycle, frozen embryo cycles, can we trust the natural cycle? Because in a hypothalamo-pituitary ovarian axis story, when the lady is going to go for a frozen embryo transfer, I'm sure she has a lot of anxiety. And she's definitely anxious, curious, worried. Now, all those things together can change the hypothalamic pituitary ovarian axis process, wherein you could just have an ovulation just because she's overly anxious. And this can happen. So you start off in an ovulatory lady that we will go naturally, just to get surprised on day 12 or day 13, finding, well, there's no follicle going up very well, and this could be entirely induced by anxiety. So we must educate our women, look into a cognitive behavioral therapy, have one or two sessions of counseling so that this anxiety can be relieved. I also use many times melatonin tablet of 3 milligram HS for a few days in these women. Obesity. Obesity also has changed natural cycle because obesity causes high estrogen levels, estrone actually. The peripheral androstenedione is getting converted to estrone by peripheral aromatase. A high estrone suppresses FSH, and sometimes anovulatory cycles are very common here. There are also subtle ovulatory dysfunction, and this is probably one of the reasons why we have unexplained infertility, because we are not able to define what are subtle ovulatory dysfunction. And a few of those unexplained infertilities are going for IVF. And then again, dysfunctional ovulatory cycle, we can't transfer, and frozen thaw embryo transfer cannot be done. So an age beyond 35 is pretty common, where again a natural cycle may not be a very ideal natural cycle. So when we say that we want to stick on or go ahead with natural cycle frozen embryo transfer, we're still going to face a few problems therein. So let's understand what could go wrong. So let's look only into the LH profile of a natural cycle, because this is very vital for us. We highly depend on the LH surge. We need to know how do we define LH surge, and what could be an LH profile. Will it differ from lady to lady? So this is a nice paper, Derrito et al. He published from France, and this is a relationship between luteinizing hormone surge and other characteristics of menstrual cycle in normal ovulating women. She published this particular study. And let's look at the LH surge profile. This is a natural LH surge. There's a 14 hours of ascending phase, a 14 hours of plateau, and a 20 hours of descending phase. The ascending phase, when it goes, it may go from, let's say, 5 or 6 IU of LH, it may go up to 40 or 50 or 60 IU of LH. In the initial 5 to 10% rise of LH, the maturation takes place. So the nuclear maturation takes place. The oocyte, which is arrested in the prophase 1 of a first meiotic division, completes its meiosis. But a good LH level of 40 to 60 or maybe 80 IU is necessary for mechanically an ovulation to take place. So the level may not go to all that level, and that can happen. And what again happens in the 14 hours of ascending phase, as the LH keeps up, with LH going up, the granulosa cell and the theca cell are getting luteinized. Theca cells are otherwise producing androstenedione, and granulosa are producing estrogen. But now, because of the high LH activity, they start getting luteinized, and the production of estrogen comes down just because the cell is getting luteinized. So E2 drops. In the plateau phase, LH remains high for 14 hours. It sees to it that every cell of the follicular apparatus, granulosa and your theca, gets completely converted into a luteal cell, which is progesterone secreting. Since every cell is getting affected by a consistent high LH level, your progesterone levels keep going up and E2 then falls. And the later part, in the 20 hours of descending phase, this is the phase, by this time, the whole of the follicular apparatus is converted into corpus luteum. The whole of it is secreting progesterone. So there's a rapid progesterone rise. So this is a typical LH surge profile, and how it affects our physiology endocrinologically is being represented here. So when we do a natural cycle, we look at the size of the follicle, we look at the estrogen level, we look at the LH amplitude, LH surge duration. So all these things collectively, in a team effort, have a good natural cycle endocrinology, wherein you have a proper surge, good duration of the surge, a proper progesterone levels. But there is quite a data is lacking on each and every parameter, and the cutoffs of these, which could differ the results. So that particular data is lacking to us. Again, there is an intrapersonal variability of LH surge. The LH surge timing is generally in the night, but then it is a seasonal variation. In winter, it will differ. In the summer, it will differ. So it's all about hypothalamic function. The hypothalamic function is related to what you see, what you eat, how much you exercise, how much you sleep, and what is the environment around you. If that changes, your hypothalamic function changes. In turn, the LH surge will be different. So intrapersonal variability of LH surge is there. Common LH surge is between 11 p.m. to 8 a.m. and LH surge characteristics will vary more at a higher age and a high BMI. There will be various LH surges, and 44% of the cycles do not show the same profile of LH, rather as shown in the previous cycle. So this is a very beautiful study by Anna Revito, and she just looked into the different kinds of LH surges. And she says that when you look at the ovulation and the LH surge relationship, well, that is different. Okay, firstly, one minute. Yeah, that is different. Like you could have ovulation occurring before a complete peak of LH surge taking place, or ovulation occurring after 1 day or 2 days of LH surge also. So just because the LH surge has taken place doesn't mean the progesterone has started rising right there and therein. So there would be an intrapersonal difference, variation could be done. On top of that, the kind of LH surge would be different. An LH surge, you expect it to go up, have a plateau and come down. But trust me, about 38% of the patients would have double spikes, but people would have a single spike of LH surge, no plateau at all. And one can have even delayed LH surge. LH starts building up, and after maybe 48 hours, it suddenly surges up. Till the time it just remains high. So true natural cycle, when we want to practice, we will have all these issues to come across our decision making when to transfer the embryo. So from the literature, what the literature says is these are different people who have done study, like your Derrito et al. That the Anna Derrito is the latest study, Park et al. And study by Allen. Allen is the one which did first. They said single peak, plateau, or a double peak, different kinds of LH surge profiles could be there. And they all said, well, a single peak plateau is seen in just 40% of the patient. Plateau is seen only in about 11%. So what's a classical LH surge is quite not commonly seen in most of the women. Don't you think this could be one of the reasons why we have a low fecundity rate compared to the animal kingdom, that our LH surges are not perfect? But if you compare to rat, an act of mating causes an LH surge in rat. So nature has just fine-tuned it so well. But unfortunately for the human kingdom, we don't have our LH surgery, classical LH surgery just in about 10-15% of our population. And otherwise, this could be one of the reasons why we say there are ovulatory dysfunctions. Again, the next problem is how do we define a LH surge? And the literature has had various definitions of LH surge. Some people have defined it as beyond 180% rise over the basal value. Some have said beyond 17 MIU. Few have defined as beyond 20 MIU. They say, well, this is an LH surge. Or some people have defined beyond 10 MIU with follicles beyond 14 millimeter. And then you do the next day, the LH goes up, and then that means it is surging. Or the ideal definition put by Irani et al., and this is the definition which has been used by Human Fatemi and Barbara Lawrence group, when they have looked at this previous diagram which I showed you that the E2 drops. They have taken this into consideration, and they say that LH going up and E2 drop by 30%, and that you say is surge, and then the progesterone coming high on the next day, and that means you can define when the LH is surging, and start of the surge can be defined, and also the ovulation, because the progesterone goes up, that's the ovulation day, and this will be an ideal definition to time your natural cycle embryo transfers. But then you come across this problem of luteinized unruptured follicles. Now, why should one get a luteinized unruptured follicle? As I told you earlier, when the LH goes up, it has to reach to 60-80 MIU for the mechanical ovulation to take place. LH can surge, but it may not reach that target. It may go to 30. So the meiosis is completed, but the mechanical ovulation cannot take place, and that would result in a luteinized unruptured follicle. So LH surge is followed by meiotic completion, luteinization, and rupture of follicle. This whole scenario may not take place. It could be just meiosis completion and a partial luteinization of granular cell because the surge is deficient. And all this is understood, but the LH level, which is required for each event, is different. As I told you, increase by 10% is good for meiosis, and you require 60 or 80 for the rupture of the follicle to take place. Suppose if you do a natural cycle embryo transfer, should you literally confirm a follicle has ruptured with fluid in POD and a corpus luteum seen, or even an LUF, just because the progesterone rise is already there and all the hormonal changes have taken place, the endometrium changes must have taken place, you should go ahead and do an embryo transfer. So luteal phase in a LUF or a ruptured follicle is of normal duration, but the mid-luteal progesterone levels are low when you have a patient of luteinized unruptured follicle. So one of the reasons of LUF could be blunted LH receptor expression, and this is commonly seen with high androgen, so polycystic ovary patient, obese patient, and then there are mechanical reasons of LUF in the form of endometriosis, pelvic adhesions, etc. And if the LH receptor expression is less than granular cell, that can result into LUF. So this set of documentation of ovulation is not common when you do a true natural cycle transfer. At least the data says that we don't look at the ovulation. But if LUF has low progesterone level, the mid-luteal progesterone is level low, should you document a USG rupture? And if LUF is there, you should not transfer. That could be. Now, no data has been published on this particular reason. It's left up to us to take a call whether you want to transfer, you don't want to transfer. In my case, I prefer transferring in spite of looking at a luteinized unruptured follicle if my progesterone on the day of transfer is beyond 10 nanograms. Because anyway, I'm supporting this patient with an added dydrogesterone or vaginal progesterone together, so it wouldn't make a difference. On top of that, I give an HCG injection on the day of embryo transfer. That again helps the corpus luteum to secrete more amount of progesterone. So in my practice, I don't look at this, but this is just a hypothetical question asked in the literature. You should, just because LUF maintains a low progesterone, if you're really adhering to a true natural cycle without any supports at all, in that particular scenario, yes, you may think of a cancellation. But if you're giving progesterone at HCG like me, I think it wouldn't make much of a difference. So if you want to know the ovulation, or when the progesterone goes beyond 1 nanogram, you say to ovulation. So if you do serial hormonal levels, and they have detected that progesterone beyond 1 nanogram can go on -3, -2, -1 or 0 days. Well, you should be doing, sorry, I'm very sorry. Sorry for this. This particular study, they did serial hormones of E2LH progesterone on -3, -2, -1, 0 days, and 0 day was labeled when the progesterone went beyond 1 nanogram. So about 20.6% had a LH rise on -2 days, 69% of the LH rise on -1 day, and 9.8 LH rise on even on 0 day itself. So if FET is scheduled as per LH rise, then 30% of the FETs will be on a different day. So in my practice, when I do natural cycle or a stimulated cycle, I don't bother about the LH at all. I do LH, no doubt about it. Whether it is low or high, it wouldn't bother me. I'll only go with the progesterone to take a call when to do an embryo transfer. We'll discuss that in detail again. So what about this? We looked at the LH profile, and let's look at the progesterone profile of a natural cycle. There is an intra-individual variation in progesterone elevation post-LH rise. And this paper, as by Coughlin et al. Has looked into, it's from the human Fatemi group. They looked into implications of natural embryo transfer. What is this intra-individual variation of progesterone rise? It's a universal assumption of period of LH rise and progesterone rise starting off the secretory transformation. But so you have an estrogenic phase. The endometrium can proliferate or mature. Proliferation is estrogen dependent. Progesterone matures. So after LH rise, when the progesterone comes, suddenly there will be a complete change into a secretory transformation. But the hormonal trajectories will differ from cycle to cycle and women to women. So human Fatemi group, they did a very interesting study. They looked at the true natural cycle embryo transfer and HCG given embryo transfers. And they looked at the results and they said, well, the results in HCG given embryo transfers in natural, that modified natural cycle is lesser than that of the true natural cycle. There were some fallacies in that study because they did only cleavage stage transfers. And they said this is basically because when you give HCG, the cyclic AMP pathway is triggered very high. And because of that, the progesterone rises much faster. Like within 2 to 4 hours, the progesterone starts rising. If that occurs, your window of implantation could shift earlier and your cycle results could be little less. That's a proposal they put in. But I prefer giving HCG to everybody. We'll come to that again anyway. So we have to remember between the LH and progesterone, it is the progesterone which starts the window of implantation and the LH does not. That we have to remember. So when we are monitoring a cycle and taking decisions, we are going to take decisions by the progesterone starting the window of implantation. So if you define ovulation as serum progesterone level exceeding 1 nanogram, and this is a definition put forth by human Fatemi, then it will go like that is your day 0, and day 1 to 3 will be a cleavage transfer, and day 5 would be a frozen blastocyst transfer. And so this is with progesterone, if you time everything with the rise in progesterone. But again, you will have to call the patient on day 9, 10, 11. Every day you're doing E2, LH, and progesterone. You're looking at the E2 going up, LH going up, E2 going down, E2 going down, LH going up. That's the start of your LH surge. But when the progesterone goes beyond 1 nanogram, you say that's ovulation day, and then you time your embryo transfer accordingly. Now, this definition of 1 nanogram is peculiar to human Fatemi's group and a few more people, I think even Barisata's group. But a lot of European studies are published wherein they're considering this level as 1.5. And they're basically extrapolating the data published by retrospective studies of Benedict et al. Of fresh embryo transfers. When beyond 1.5, they had an endometrial, this is probably extrapolating from that, but they consider that as 1.5. Now, when you do natural cycle transfers, the biggest advantage is you have a very wide window of implantation. And this is a very beautiful study done on this. They looked at a nice study. They said that the window is wide. They had a flexible timing of 85 long natural cycle in embryo transfer natural cycles. And what they looked at is they defined LH surge as a surge beyond 20 MIU. And FET was done on day 6 or day 7 of the LH surge. Look at it. They timed everything to the LH surge and not to the progesterone rise. So they had 3 groups. One group, LH beyond 20. And the next day, either the reading dropped the next day or it was not tested because the patient was coming from a long distance. But they assumed that since the definition was LH beyond 20, they assumed that as your day 1 and day 6 they transform. Group 2 was LH was done once, it was beyond 20, then they did one more LH the next day, it was beyond 20. So the LH was rising. That means the LH surge which was noticed on the previous day was true. And from that first surge, on day 6, they did embryo transfer. In group 3, it was same as group 2, but a blast transfer on day 7. It was like the LH went beyond 20 today. Next day, it was still beyond 20. They consider the first beyond 20 as the surge day, and day 7 or day 6 they transfer. Day 6 is group 2 and day 7 on group 3. This is what was followed. And look at the pregnancy rate. It didn't make a much difference. The ongoing pregnancy rate in all 3 groups was almost the same. So when you do a natural cycle, and if you're timing with an LH surge, then your window of implantation is quite big. But in our practice, in my practice, I don't do this particular thing. I don't go by the LH search, and we'll just dissect that point again. So, but when you do true natural cycle FET, it will demand urgency, and availability of the team would be there, and you'll have to really call the patient every day to get your LH-E2 progesterone tested, and then take a call. Many of our clients will be coming from a distance of 40-50 kilometers. Coming every day would be a problem, getting so many blood tests done, etc. And again, a certain amount of urgency or availability of the team would be necessary. So when we compare natural or modified natural cycle, where you give HCG injection to program, your chances of hypertension is quite high with program cycle. Again, high dose and cost is with the program cycle. Less patient friendliness is there because patient has to take a lot of tablets and injections as well. There is increased small for gestation age as well as LGA, miscarriages and thrombotic events because of your pushing up so much of estrogen could also be high. So HRT is not something which is very patient friendly thing. But only important is the flexibility. Flexibility is more with HRT than natural cycle. That is just an assumption. I feel even natural cycle can be made flexible as well. So even a natural cycle can be flexible. It is friendlier to the patient and clinician both, and it is going to be less expensive. And again, least perinatal complications. So how do we make a natural cycle FET flexible? Let's go into that a little more. Let's understand different ways. I'll just wait here. Any questions? Hello.
Sir, what progesterone level you are taking from the day 0, 1 or 1.5?
I'm taking 1. I'm not taking 1.5.
Okay.
Okay. Can I go ahead? Is it okay to go ahead?
Yes, sir.
Yes, sir.
Okay. Now, before I go ahead, let me just pause and just explain how I do it in my scenario. Then we will go to the flexibility part of it. So I would either do a letrozole cycle starting on day 1. I would put the patient on 2.5 milligram twice a day letrozole for 5 days. Many of the patients take it from day 3 also, but I would prefer going on day 1. Then I give this is pre-planned, so I give the tablets before and only tell them when you start your menses, just start letrozole and come and see me on day 3 for a baseline evaluation. But you can start on day 1, 2, 3 as well. Or if it is a true natural cycle, I will just call them on day 3. Then I call them on day 10, day 9 or 10. It will differ from depending upon the cycle length. If somebody is having a shorter cycle, I would make call on day 9, or even on letrozole, I can sometimes call on day 9. On natural, I can call them on day 10, day 11. When they come, I just do a scan and find out, is there any follicle beyond 16 millimeters? And then I look at the endometrium, and if the endometrium is going beyond 6.5 millimeter, this is my cutoff is 6.5 millimeter. If it is 16 millimeter already follicle, and this is your endometrium is 6.15 millimeter, I will just do an E2 LHM progesterone. If LH is normal, E2 is beyond 100 picograms and progesterone is less than 1, okay, I said fine, I have a choice to give HCG, or I can just wait for 1 more day. Generally, I wait for 1 more day because I would like the follicle to grow a little more, maybe to 18, 19 millimeter in a true natural cycle, which can commonly happen. In a letrozole cycle, sometimes it can trigger a little early, but otherwise, true natural, you can definitely go a little more. And then I will call them the next day, again do an LH2 progesterone. The moment I see, I'm talking of true natural or letrozole, whatever, moment I see the LH is going beyond 10. Okay, so LH, first LH was less than 10. Next day I did it, now LH is going beyond 10. Now this can happen on 10th day, 11th day, 12th day, whichever day. So let me give an example. Today the patient is come on day 9. I have a follicle of 16 millimeter. I'm calling the patient next day. Suppose today is day 9, the follicle is 14 millimeter. I will not call the patient the next day. I'll call them after 2 days, because we understand for a natural follicle growth, it will take 2 more days to make it 16, 17 millimeter. So that flexibility will be patient to patient, will be different. But moment, if I have one report of LH to progesterone where LH is less than 10, E2 around 100, or maybe less than 100, or whatever, progesterone less than 1, and moment I see LH going up, E2 is beyond 100, progesterone less than 1, that is the point I will give HCG. So in a true natural cycle, I would prefer LH to rise and then I give HCG, because if you have one reading, let's say day 10 the client comes, and day 9 or day 10, your E2 is, let's say, 100 picogram, LH is low, progesterone is also low, and you give HCG. We don't know how much time the endometrium is exposed to estrogen level of 100 picogram. Moment you have an LH surge taking place, or LH is going up, that means a reasonable amount of duration the endometrium is exposed to estrogen, and all the receptor formation of progesterone receptor, everything is formed very well. Because if you go back to Spiroff, it was said when there is a 200 picogram of estrogen level, for 50 hours, LH surge starts. So when the LH starts rising, that means the endometrium has exposed to a certain duration of estrogen, and that hypothetically I feel is very important. There's one retrospective study to support what my saying is. I'll come to that study as well. And then I will give HCG. So if I give HCG today, like cleavage stage, if I'm doing a blastocyst transfer, today is Thursday. So next Thursday, I will do a blastocyst transfer. And if it is a cleavage stage transfer, I think on Tuesday, I will do a cleavage stage transfer. And I would put them onto progesterone, like dydrogesterone and vaginal progesterone, starting 2 days after the HCG trigger. So HCG trigger goes in the night. One day, next day, nothing. Uska next day, I start with dydrogesterone and vaginal progesterone. And on the 6th day of that progesterone, I'll be doing a blastocyst transfer. That's typically I cycle do. And I do a progesterone level on the day of embryo transfer. In a natural cycle, a stimulated cycle is always good, because your corpus luteum is secreting progesterone. On top of that, I give one more HCG injection of 5,000 IU on the day of embryo transfer, just to keep more progesterone in the later part of the cycle. That's a typical cycle I do. I would invite any questions and criticism on this particular protocol which I shared with you, because I want to know whether I've confused more or.
Sir, I want to ask about letrozole cycle.
Yeah.
This is the natural. And then what about the letrozole cycle?
Yeah. So, madam, you are so right, madam. See, what happens in letrozole, what I have realized, see, if you give letrozole from day 3 to day 7, and if you call the patient on day 9, the E2 is still low. See, letrozole washout period is 48 hours in literature, but not everybody will wash out the E2 letrozole in 48 hours. There could be some patients who would, the low E2 will linger for some more time. So many times you'll be surprised that if you just rely on the E2 level and you take a decision to cancel your cycles on E2, you will face more cancellations of cycles of a low, because of low E2 in a letrozole cycle. This is on day 10 or day 11. So I prefer starting letrozole on day 1. So when they come on day 9, they have finished the letrozole 4 days back and the E2 is going up. So you are able to match the things much better, and you don't create any confusion in your mind. Okay, so that is one. And secondly, obviously, when the follicle touches 16 millimeter and onwards, I would just give HCG injection and do the blastocyst transfer, as I told you, for the natural cycle.
Sir, why you are not waiting follicle to grow like 18 and 19 millimeter?
Why you can let me clarify. I would wait the follicle to go to 18, 19 millimeters. 16 is minimum, I'm saying. 16 is my minimum criteria. Okay. I would wait for 18 to 19. Bigger the follicle, better corpus luteum, definitely. So I would be waiting, no doubt about it.
So what is your endometrial thickness cutoff, sir, for transfer?
Yeah, mine is, on HCG trigger day, as low as 6.5 is my cutoff. I don't cancel the cycle just because I've achieved a low endometrial thickness. It may happen sometimes, like today it happened. I had a follicle of 20 millimeter and endometrial thickness was 4.7 millimeter. I'll discuss what I did for that. In such a scenario, initially what we used to do was I used to cancel the cycle. I said I wouldn't do it, but I would do everything. I would give them HCG and call them on 8 day and look at the endometrial thickness then. If the endometrial thickness then is about 8 millimeter and more, that's when the blastose is going to be there. I would say next time we'll do it, we'll neglect the endometrial thickness and we'll go ahead and transfer the embryo.
Okay, sir.
Can I resume?
Sir, it's not mandatory to wait for more than 7.5 for the implantation to happen in natural cycle, unlike HRT cycles.
You're asking the endometrial thickness, am I right then?
Yes, sir. It is, sir.
Actually, I'm not being very critical, but this is what has happened over a period of time. Over last 2-3 years, after reading so much of literature on endometrial thickness, I feel we are oversensitive to the endometrial thickness because endometrial thickness is a very small determinant unless it's a pathological endometrium. So, as I told you in one, I give it two ways. I'll tell you. One is suppose the endometrial thickness is less than 6 millimeter. Will I take a decision to transfer? I'll say, well, I'm not going to transfer, but I'm going to prepare you for transfer. I will see the endometrium on the day of transfer. If it is touching 8 millimeter, which most of the times, yes, it will be touching 8 millimeter because your estrogen progesterone is going to go up, you will still go ahead and transfer. Okay, so I would, and there is one more way to change it also that I will discuss when I come to flexibility. So endometrial thickness is not something worries me much. Whatever thin endometrium I see and I diagnose as refractory thin endometrium is basically which are surgically treated uterine cavities or some other reason. They are really, really refractory, and the pregnancy rates are pretty low in those patients. Although I'm not very sensitive between, let's say, 5.5 to 7 millimeter. I'm not greatly sensitive. I will never take a decision to cancel the cycle on these grounds.
Okay. So one more doubt. This HCG trigger, whatever we are giving today, does it have any time to start progesterone? Like we are considering on Saturday it to be day 0 for progesterone, irrespective of time of trigger.
So yeah, you're right, madam. So let me again tell you. So let's say today is Thursday. Today my follicle is beyond 16 millimeter. Endometrium is beyond 6.5. I will give HCG tonight. Okay, let's say 7 p.m. I give HCG. And Thursday, Friday, Saturday, I will start with progesterone. Okay, Saturday's progesterone will start. Saturday progesterone will go till Wednesday, and Thursday again in the morning we'll do a serum progesterone level and we'll transfer the embryos in the afternoon. So our time of window of implant is about 164 hours. Generally about 160 to 164 to you can say 158 hours after the HCG goes in. But I'm not worried. I'm not so strict about that hours. Please don't misunderstand me because the window of implantation is wide, so I wouldn't be worried much.
Okay, sir.
Don't start calculating the hours because then you're putting too many restrictions and you're putting too many censorships on doing a transfer of embryos. Okay, can I go ahead, ma'am?
Yes.
So this is the situation. You have now we are looking at the flexibility part of it. So you have a follicle of 16 millimeter, endometrium beyond 6. So what are our choices? Number one, we give an HCG injection and do blast 0+7 or cleavage 0+5, which we just discussed. The second option is don't give HCG, just start progesterone from that particular day and make a natural cycle into an artificial cycle. So start progesterone like vaginal, diprogesterone or IM or aqueous IM progesterone, whatever is your artificial cycle regimen. Okay, so herein we need to understand one concept. And let me quote a study done by George Grisinger here. What they did was they looked at the true natural cycle. When the follicle was 16 to 18 millimeter and the endometrium was 6 millimeter and above, okay, they started the patient on vaginal progesterone. They started the patient only on dydrogesterone. They put them onto dydrogesterone 10 milligram 3 times a day and call the patient on day 6. Okay, so today is Thursday, so they will call the patient on day 6. That would be maybe next Tuesday, day 6. So they have given 5 days of progesterone. What happens is when your small progesterone is given in an estrogenized condition, in the follicle beyond 14 millimeter, estrogen is already high. When you give a small progesterone, that initiates a trigger of LH, and LH surges because you're given a progesterone. Let me just go back and like a deja vu feeling. we get so many patients who are 38, 39 years who are fertile, had their pregnancies, and they have postponed their cycles, and they want to take some progesterone. And you prescribe them premalutein or something, she does not get a period and comes back with a pregnancy. And you're surprised at 38, 39 years, how come she had a pregnancy? And your progesterone landed up there. You wanted to induce a menses, but she got pregnant. This is because she was having a dominant follicle. It was just not rupturing. You gave progesterone, that started a LH surge. That follicle ruptured. They had intercourse around that time and she's got pregnant. So it is a progesterone, a small amount of progesterone surges the kisspeptin and the LH surge, and that is used here. So what they did in that particular study, look at the study again. Natural cycle, 16 millimeter, 6 millimeter endometrium, 16 millimeter follicle. Start the dydrogesterone. Day 6, call the patient for transfer. On day 6, do a scan. The follicle is already ruptured, which you saw on 5 days back. Now look at the serum progesterone level. The serum progesterone level is beyond 10 nanograms. You transfer the embryo. Now, where does progesterone come from? Because dydrogesterone does not get measured as serum progesterone. It is dihydrodydrogesterone, which is to be measured to know what is the serum level of dydrogesterone. So this progesterone has entirely come from the ruptured follicle. So that itself strengthens that if you have that flexibility of just putting the progesterone right in there and transfer the whole thing into an HRT cycle and going ahead. So for example, today is Thursday and my follicle is 18 millimeter. I think I have a slide like that. 1 minute. Yeah, this is the slide. So let's look at the calendar and put this into calendar. So I'm seeing the patient on 10th of August, and this follicle is beyond 16 millimeter, endometrium is beyond 6 millimeter. If I give HCG, my transfer will be on 17th of August. That's again a Sunday and I'm not available. I have some lecture or some function at home. So I have to change it up. So I put the patient onto progesterone on that particular day, go for 5 days, 10, 11, 12, 13, 14, day 6 is 15. I'm available and I can do a blastocyst transfer. So you can do that conversion from HCG to vaginal progesterone or addition of progesterone and that particular day. It is called natural phase progesterone induced natural FET cycle. This is the way you can adjust it up. I hope this makes it clear.
Yes, sir.
Yeah. Now the next question is HCG trigger, yes or no? Like, would you like to go by true natural cycle or you want to give a modified by giving an HCG trigger? So these are studies published by Fatemi et al. As I quoted earlier also in Correct. They said true natural is superior to MNC HCG trigger. And they looked at the interim analysis and looked at the ongoing pregnancy rate of 31.1% in true natural and 14% in modified natural. And since the difference was so much, they terminated the study. But then there was a criticism came with Montagut et al. In 2016 in human reproduction, because in the earlier studies, they only transferred cleavage stage transfers and very few modified natural cycle had LH rise and no luteal support was given in modified natural cycle. And FET was scheduled at identical time, while ovulation after HCG may be later than a natural LH surge. So they said there is a methodological problem, and that's why you cannot interpret saying that true natural cycle is more strengthworthy, is better than the modified natural cycle. Then the question is there a critical LH level for HCG trigger after detection of LH surge in modified natural cycle? Many a times you'll be, you get two clients today, let's say both are doing for natural cycle. One client is having an LH of 7, the other is having an LH of 18. Now, will there be a difference in the result if you do give an HCG trigger and do an embryo transfer on day 8? So HCG trigger natural cycle FET is preferred because better timing, also supports the luteal phase, and daily hormonal monitoring is not required. This is a retrospective study of 1,168 modified natural cycle FETs. They did a day 2 scan, then they did day 9, day 10 scan, repeated scans every other day. When the follicle was beyond 15 millimeter, they started measuring LH and E2 every 24 hours. LH beyond 15 was defined as beginning of an LH surge, and beyond 40 was defined as a peak of a surge. And HCG was given at any time between the LH of 15 to 40. So this is one interesting thing, So people are generally following to give HCG when the LH starts rising, and that comes back to my old theory that endometrium should have an adequate amount of estrogen exposure. So they looked at 3 groups. The B, C, D group looked at 15 to 24, 25. I had D's beyond 40, and A group was LH beyond 14. They triggered the next day because the patient was staying away and the patient could not come back the next day. That's why they just triggered empirically on the next day. And they said that higher LH levels on the HCG trigger rate does not negatively affect ongoing pregnancy rates. So this gives a very clear idea. You do LH, no doubt about it, but it doesn't make a difference. Your HCG trigger can still go ahead. LH is basically done to fine-tune your HCG trigger. Can you postpone your HCG trigger by a day or more so that the endometrium gets better exposure to estrogen? The advantages of HCG, it mimics nature. So you know what happens when a blastocyst comes? The blastocyst does secrete HCG, and it's a hyperglycosylated HCG molecule. And I call it, this HCG is very necessary. This HCG goes to the endometrium, and it's like, it says knock knock endometrium, and embryos arriving soon. So this HCG acts on the HCG receptor in the endometrium and prepares the endometrium better to receive the blastocyst. So HCG has some role to play there. So that could be mimicking the nature by giving HCG in an MNC cycle. But again, coming back to the same thing, so don't bother about the LH levels, because LH levels do not create the window of implantation, progesterone does. Then what is the role of human chorionic gonadotropin directly in bodies? This is a very beautiful paper, little older one, 2007 publication, a very nice paper. And they looked at what could be the effects of HCG. So HCG gets the insulin growth factor binding protein level 1 less, so destabilization, prolongation of endometrial receptivity is there. VEGF is better, increased angiogenesis, your leukocyte inhibiting factor is increased, so trophoblast differentiation better. So all these molecular mechanisms, HCG could be making a difference. So they propose that having an HCG MNC cycle is better than going for a true natural cycle. And coming back to flexibility a little more, I'm putting that retrospective in red because there are no prospective studies on flexibility. Most of the studies is just an analysis of the real world data and retrospective analysis of those data which is being published. And this is a study wherein they did natural proliferative phase frozen embryo transfer cycle. So about 5,000 FET cycles studied. It was natural cycle or natural proliferative phase, had a better progesterone levels on the day of ET. So this is like as I told you earlier, just put progesterone when the follicle is dominant and then transfer the embryos. So the protocol was day 8 onward, they measured the ET. Once it was beyond 7 millimeter, vaginal progesterone was started, 400 milligram twice a day. The serum progesterone was less than 1.5 regardless of follicular diameter. So, in this particular study, they used progesterone cutoff as 1.5. As I told you, I use it 1. And blast was transferred in 0.5 days. When they started progesterone, obviously 0 plus 5 days, you will transfer the blastocyst. A serum progesterone measured on embryo transfer day, if it was less than 8.5 nanogram, they added an intramuscular progesterone as well. And they did go ahead and transfer the blastocyst. And look at the pregnancy outcome. Well, the pregnancy outcome in a natural proliferative phase cycle was good enough. Okay, compared to the artificial cycle, even the miscarriages rate was less. So definitely, in this particular cycle, adding the artificial cycle treatment after a follicle is dominant and you have a corpus luteum makes a difference. So timing of embryo transfer is dictated by ovulation in modified natural cycle FET. It shall we modulate ovulation to suit and schedule an embryo transfer, and will live birth rate be similar? So can we do something to modulate the ovulation part of it? So this is another paper, again, retrospective analysis. It's the latest publication. They looked at adding a short duration gonadotropin releasing hormone antagonist to natural cycle. So this is what I'm doing recently. I've not done beyond 4 or 5 patients, I must say. Like today patient, I did this. This patient had a follicle of 19 to 20 millimeter size. The endometrium was 4.7. And today was day 10 of a cycle. So I told her, please take tablet elagolix, 150 milligram every day from today for 3 days. And for next 3 days, please take an HMG injection of 150 IU. So I'm going to call her after 3 days. I expect the follicle will not be ruptured and E2 would be high because I'm giving HMG. The elagolix will not affect the growth of the follicle. And I'm giving more time for the endometrium to grow. So I will see, but obviously a lot of counseling will be done that sometimes the follicle may just rupture and I may have to cancel. Anyway, the endometrium is thin, and this is one way I can help you out to do the embryo transfer rightfully in this particular cycle. That's the way we counsel. So this particular, that concept was taken from this particular study. This is a retrospective cohort study of multiple centers in USA. Frozen embryo transfer artificial cycle compared to natural cycle FET. They were later counseled if the FET falls on a Sunday, and additional medication will be given to alter the ovulation time. This is the way they counsel, and that's why this data was available to them. So women with a follicle of 14 to 17 millimeter on Friday with a risk of ovulation and surge before Monday were administered HMG or RFSS 75 IU and injectable ANTA they give. I give Elagolix and Indian HMG 150. I don't use Menopur here. And this is the protocol. I will send this slide also to all of you. And this said that the peak size of the follicle, the peak estradiol levels were higher when anti-HMG cycle was given than the true natural cycle. The HCG positive was 81% in ANTA plus HMG and 64% in natural cycle. So all ratios are definitely in favor of prolonging the ovulation time. So again, coming back to the same story of exposing endometrium to more estrogenic activity. So there again, anti-HMG had more clinical pregnancies, though statistically not significant. So live birth rate with anti-HMG, postponement of ovulation 55%, natural cycle 52%. And the advantages, more follicle size, more E2, lower LH till trigger, it targets a good follicular size, and good follicle means good corpus luteum later, and probably hopefully your perinatal outcomes are also good, but no study on the perinatal outcome is published. I'm just logically correlating things here. Contrary to the above study, second part is, can we trigger early? Why not? Why waste? Why go ahead? Let's go ahead and trigger at a lower size of the follicle. And there is again a retrospective study available here. And this is highly quoted by a lot of people, a lot of conferences. You must have seen this study. Somebody is mute, somebody is unmuted, somebody is unmuted. Am I audible? Hello? Hello?
Yes,
sir, you are.
Yeah. Okay. I'm sorry. So I'm sorry for that interruption. So this is an old study. I think a lot of people must be quoting this particular study of Carlos Alonso. It's again a retrospective analysis of his data. This is contrary to the true natural cycle. A mature follicle is not necessary for modified natural cycle. We need a functioning corpus luteum and a good amount of estrogen, progesterone, or good vasoactive substances. So this is a study to know if modified natural cycle allows flexibility in triggering. And they proposed on this hypothesis that LH receptors are fully expressed by 12 millimeter of follicle size. So full maturation for 16, 18 millimeter may not be needed. You can give a trigger a little early as well. So they had a large number of patients there, and they looked at the follicle sizes of the trigger variant. Look at the last three boxes. Some patients were triggered between 13 to 15.9, few from 16 to 18.9, and between 19 to 22. And they said across the triggering follicle size criteria, the pregnancy rates did remain very well. And the follicle size, then put an area under curve, the follicle size was not a factor which will determine success or not a success. And looking at this, they said, well, you can make your natural cycle more flexible by planning your trigger a little early. So here in the cases, let's take an example. Like today is the follicle is 15 millimeter, and today the endometrium is 6 millimeter. If I want to call them tomorrow and give a trigger tomorrow, the next transfer is going to come on the next Friday, but next Friday I'm not available, then I will give trigger today itself. So that is what this paper is talking about, and says if you give a trigger for a follicle size, anything between 13 millimeter to 22 millimeter, your results do not alter, and that's what they proved in this particular study. So when that is possible to apply, again, retrospective study. So look at follicle trigger 13 to 22 millimeter. Sorry for that. And blast, they did on 0+7 or cleavage stage 0+5 after giving the trigger. But we definitely need further studies on prenatal outcomes confirming that the corpus luteum formed by a 14 millimeter follicle and that formed by the 20 millimeter follicle. Will there be a difference in corpus luteal functionality, immunomodulation, and also difference in the angiogenic factors secreted so that your preeclampsia is prevented? So unless those studies are available, I think this will be a little risky to practice. So ongoing studies these are the ongoing studies. I told you the first one that you need 1,600 patients to do a good study. These are the ongoing studies, that NACPRO and Antarctica trials. I just put on the ChatGPT to compare the studies, and the sample size is just 788 participants and 1,000. So both the studies together are going to match that status, and both the studies together will definitely give us an idea on statistical significance. So one study, NACPRO is not recruiting anymore. and Antarctica is also, the results are going to take some more time, looks like. So both are randomized control trials. They're comparing the true natural cycle to the programmed cycle and focusing on the NACPRO focusing on the preeclampsia risk and the cumulative live birth rate, while the Antarctica is focusing on the live birth rate. Let's wait for the results of these particular trials. Now, suppose you're doing a natural cycle transfer, should you give a luteal support? We all give a luteal support, definitely. These are two meta-analyses I looked into. And they all agree that, yes, you must give progesterone in spite of giving your HCGs or natural cycle. It is worth giving progesterone because all clinical pregnancy, live birth rate, it does make a difference in improving. Well, the miscarriages rates are also a little lower. So natural LH search, can you use a dipstick kit? I think that is the last thing. We don't use it. A difference in urinary clearance of LH will affect the onset of urinary LH positivity. Roos et al. Did a study, transvaginal USG for ovulation combined with serum LH and urinary LH. They correlated well in 40 regularly menstruating women. But urinary positivity could be delayed, and will that delay affect? We don't know. So I generally don't go by the urinary kits. And this is one paper I'm going to say, and we probably will stop here. Again, going back, my hypothesis that we should have an adequate length of estradiol exposure comes from this particular paper, that length of estradiol exposure beyond 100 picograms for follicular phase will affect the pregnancy outcomes. And they looked at the data that when the estrogen exposure was beyond 100 for beyond 3 days, the pregnancy rate, and less than 4 days and more than 4 days. The more than 4 days, the right-hand column, look at the pregnancy rate, 75%. So it is early trigger is something which is no in my practice. I don't mind postponing the trigger and then going ahead further. Well, can I stop here? But this is going to go a little. Hello. Hello.
Yes, sir.
Can I stop here?
Your wish, sir.
We can do the we can do the rest of the things a little later, because it is going a little too much, I feel. I'm so sorry to have taken a long time.
I think it was interesting, so we didn't want it to interfere in between also, sir. I think Dr. Sharmila, you are here?
Yes, ma'am. Yes, ma'am.
Yeah. You can ask the questions in the chat box and take it further. It will also be there.
Chat box
Very
questions.
detailed, and I think the concept of putting the HRT was enlightened in a very good way. I think for any person who's going to do the HRT cycle, to knowing or a FET protocol, to know the concepts of why this natural proliferative cycle, and what is a modified stimulated, what is stimulated, what is suppression and followed by HRT, all those, what is the concept of giving HCG, all that has been very clearly mentioned. The physiology and the treatment protocols are enlightened in the best way. We have some questions here, so, and you can also post your questions in chat box, and I think Sahiti, they can also unmute and ask also, I think. Yeah.
Sometimes I feel, Aruna, where I have confused people by putting a lot of studies.
Yeah.
I think there was one question on 2 consecutive LH values for group 2 at how many hours interval. I think they did it at 24 hours in that particular study. One minute, there's one more question. Can I just there's a question. Can I read that question up? It's for scheduling purpose. According to embryologist date, shall we give direct progesterone instead of HCG and transfer after P plus fly? Will this late LH rise after progesterone hamper the cycle? I think from the scheduling point of view, if you want to do early transfers, then adding progesterone or natural phase proliferative conversion of natural cycle transfer is worth it. If you want to postpone it, giving HMG and anti is worth it. And that's the way the scheduling can be done, whichever suits your embryologist visit.
Sir, I want to ask where you are using HRT in your practice.
No, what again? Come up again, madam. I'm sorry.
The hormones induced FET.
HRT. Yeah.
Ji, ji, sir.
Indication you're asking in my
Yeah,
practice.
Yeah.
Yeah, I think it's a very right question. I put it for all my patients of adenomyosis, madam. Wherever I've given suppression of GnRH agonist in patients of endometriosis or adenomyosis, especially in adenomyosis. Endometriosis, we just operate and clear the disease. Adenomyosis, especially again, outer wall adenomyosis, patient asymptomatic, and she's developing a good endometrium naturally, and she's having a good junctional zone, I won't suppress it. Only adenomyosis, which is diffuse, quite a significant adenomyosis, heterogeneity or ecogenic changes in the myometrium are there. At places the junctional zone is affected, and then I would downregulate them. Either nowadays I downregulate with elagolix only, but earlier I used to be leupride depot. Otherwise, nowadays I just downregulate with elagolix and letrozole together. So elagolix starts after 10 days of elagolix, I add letrozole and downregulate nicely for 40-50 days, then stop elagolix and letrozole and start off with your estrogen tablets. So adenomyosis is the main indication I give these kinds. And sometimes I give it for refractory thin endometrium. When I tell you refractory thin endometrium, they are basically previous DNCs or previous Ashermans corrected. Many a times we have limitations of taking your estrogen levels up with making them ovulatory. So just pumping in more and more estrogens can take the estrogen levels a little high, I feel. And because even if you use HMG and FSH injections to stimulated FET, for stimulated FET in these particular patients, you may have multifollicular development, which will confuse you, and you don't want to take a risk of OHSS. So, again, so in these patients, I use HRT cycles. And obviously, poor ovarian, your premature ovarian failures, your recipients who are, nearly menopausal kind of stuff, your 40, 44, 45-year-old patients, they will go for HRT once.
So sometime in PCO, even after starting very small dose of estrogen into, on the 6th day we find 8 millimeter endometrium and ecogenic. So what should be done in such a case?
That's what we are getting really oversensitive on this diameter of endometrium, I feel. See, it is the style of a particular person. I always give an example to people that, everybody's nose is different. So somebody has a big nose and somebody has a small nose, but they all have the same aromatic feeling and happiness. So similarly, this is just an endometrium which is proliferating a little faster. Doesn't mean that it is a pathological endometrium. So you can take an adequate, I don't bother much. And if you look at the studies, with every millimeter increased thickness in endometrium, the pregnancy rates in fresh embryo transfers have increased all the way to 14 millimeter. Okay, so and that is true for frozen embryo transfer in HRT cycles also. So I wouldn't bother much. I would just take that as a normal endometrium.
Thank you.
I think when you measure the progesterone, it is less than 0.8, that whatever institutional protocol that you have, thicker endometrium doesn't matter if the progesterone is.
Yeah, absolutely. So true.
If you wanted to, if you think that she has had a premature ovulation or anything like that, you can check the progesterone as additional measure. As Dr. Sachin has told clearly, every patient has their own threshold. Sometimes it's only 7 and sometimes, and what we do generally is if the patient is having this endometrium, usually during stimulation only, you will know what is happening. So maybe a very low dose of estrogen is enough if you're going to give HRT.
Yeah,
even twice a day and then 3 times a day, just it's enough. You need not put 8 mg per day and all for these patients. Just you give a low dose, or natural cycle is very good for these patients because they are inherently following a good endometrium. So just follow their natural cycle and then do. Dr. Neena, yeah.
Thank you.
I think you told somebody as Kavya Bhaskaran. As that questions are answered, Kavya Bhaskaran, sir.
Which one?
Answered all that. Starting progesterone at 16 millimeters without HCG, is it okay? If follicle doesn't rupture, means would it affect the success and corpus luteum?
See, there are no studies published on this particular question. I must say that, but this is a logical inference we derive from various studies which can contribute an answer to this particular question. So starting progesterone 60 millimeter without HCG, is it okay? Yes, it is okay. Is it okay if the follicle does not rupture? Will it affect success rate? Yes, it will affect success rate, but you are given progesterone. How can a follicle not rupturing affect a success rate? By keeping the progesterone low. But you're giving progesterone here. So I don't think that would make a difference.
But whenever we have seen these patients, we have seen them during the luteal phase, at least they have ruptured the follicles.
Yeah. Most of them rupture.
Yeah, most of the time on the day of embryo transfer, they've already ruptured the follicles. And the beauty, they tell the cyclin, these hormones are going to relaxin, and all those things are going to help in having a threatened miscarriage being reduced. So that is also use of doing a modified stimulated cycle. So most of the time it is a corpus luteum which forms, and I think just the timing we miss it and we start the progesterone. And it will be very tedious to see when it ruptures and then start. So when you start progesterone, as Dr. Satya has told, it is easier. It is as easy as HRT, that you start on any time and then do it.
Yeah, and secondly, I feel one can even add an HCG. Like you have taken a decision to convert to progesterone. So start progesterone today. In the evening, give HCG injection also. It's not going to spoil it up anyway. Your window of implantation is going to be as it is, and you are assuring some rupture as well. So there's nothing wrong in doing these kinds of modifications.
I think any questions, Dr. Sharmila?
Yes, ma'am. One doctor has asked 45-year single embryo for FET regular cycle. So for FET, can we start with HRT from day 2?
Yes.
Or anything to be done in the previous cycle or added in the previous cycle?
Single embryo transfer, FET regular cycle. Yes, I think you can start from day 2, nothing wrong. Just do a scan and see that the endometrial thickness is thinned out. Sometimes she might not have shed the whole endometrium. They can wait for a day and then start otherwise. But you can definitely start. Anything to be done and added in the previous cycle? I generally don't. And that opens a complete Pandora's box. So, I want to put up one small question to all of you, that what is the agreed treatment for thin endometrium? Thin means a thin endometrium which has been persistent, if in spite of your HRTs or natural cycles, it's been persistent. Don't talk of PRP, but for PRP, tell me what is the treatment, what you feel do for your case.
Sir,
I'm not
I will
questioning, I don't want to discuss this issue.
Yes, I will go for the natural cycle and see what is the normal thickness of the endometrium. If the morphology is good, then I will transfer even if the endometrium is 6 or 6.5.
Absolutely, true natural cycle makes a difference. But all those studies which have been published by Gill et al., they've been published by Baris et al., they all talked about euploid embryo transfer. So I think we need to think of, when you face continuous thin endometrium, think of doing an euploid embryo transfer. Rather than correcting the endometrium, correct the seed. That's what I feel. The literature is too much talking about a euploid embryo transfer, irrespective of the endometrium. It is given a consistently good pregnancy rate. It was an initial study by Baris et al., but now the Gill et al. Study is also saying the same thing, that endometrium doesn't make a difference.
Yes.
So, sir, I have a doubt. When you do a transfer with a thin endometrium, is there a chance of ectopic pregnancy? Like you said, the endometrium doesn't.
See, one of the reasons of ectopic pregnancy is an abnormal uterus. So any patient who has adenomyosis, junction zone problem, thin endometrium, nature is so beautiful. Nature says this is not the right environment, and it goes. So any of these uterine abnormalities could be one of the reasons of ectopic pregnancy.
So how less? How less thickness?
But I think number one, I will never sensitize my patient. Will I ever sensitize my patient? You have thin endometrium, you have chance of ectopic. Never.
Yeah.
I understand. So I don't think that we should sensitize unnecessary things which is a natural event and which is acceptable to the patient and us as well.
Okay. Another question. After starting progesterone, in few cases, endometrium becomes compacted and thickness on the day of transfer is very less compared to the day of start. Is it okay?
It is absolutely okay. What happened was Robert Casper published a beautiful study, and the title of the study was "Why Euploid Embryos Don't Implant." And in that particular study, he said compaction of the endometrium, is something. I think in his particular study, the compaction had a better pregnancy rate or something. I don't even remember that study, because there was an inherent fallacy in the materials and methods of this study. On the endometrium on the day of HCG was measured transvaginally, and the endometrium on the day of transfer was measured transabdominally. So there was a methodological difference. So then there came many more studies All the studies said that compaction, same endometrium or growing endometrium doesn't make any difference. I don't even look at the compaction.
Okay.
I would go ahead and
Sir,
transfer.
is it like any cutoff for the compaction, sir? Till this much
So
compaction is
So
acceptable.
they have looked at a reduction of 1 millimeter, 2 millimeter, and 3 millimeters. Still, the results are same. So don't make no point.
Okay.
So
Even
as you know, I feel as we are not doing now progesterone levels on day of HCG, and that because we are doing FET cycles, so that level doesn't make much of a difference to us, our decision making. Similarly, slowly, all these endometriums and thickness and compactions, all this will go away moment to shift to euploid embryo transfers.
okay. So there is another question. So what about your opinion regarding day of FET? Whether it is P+5 or P+6 in HRT FETs for day 6 embryo?
Yeah. So see, I give 5 days of progesterone and 6th day morning I do embryo. Afternoon I do embryo transfer.
Even for day 6 embryo?
Yeah, day 6 also. I give 5 days in the sense.
There are some there was one study done by Nihar and published in Indra, where they compared day 6 embryo on day 7 of progesterone, because we all give 5 days progesterone and transfer on 6th day. They told that it was almost similar. But what Dr. Sachin has told is we all do the transfers, whether irrespective of the day 5 or day 6 or sometimes even day 7 embryo, on giving 5 days progesterone and 6th day. Embryo formed late. But the endometrium receptivity, we keep it as 120 hours plus or minus 3 hours.
Absolutely. Yeah, that's absolutely on the top. And again, now when we look at all those studies, we have to read only studies where euploid embryo transfers have been done.
Yes.
Because the moment you have untested embryo transfer, the results are not replicable. If you have a replicable result, only euploid embryo transfers will be able to replicate those studies. So that wouldn't make much of a difference.
How much of your patients out of the subject, but so how many percentage of your embryo transfer are euploid embryo transfers?
Majority.
Everybody
beyond 35 is euploid embryo transfers.
Superb. Yes.
Everybody. And even at a younger age, I give them an option. I discussed this in detail, that just testing for euploidy does not mean that you're going to have a higher pregnancy rate, but probably I may be able to reduce time to pregnancy, and yes, I will be able to satisfy your curiosity better. So if you look at the studies, irrespective of the age, when they did first embryo transfer as a euploid embryo transfer, the pregnancy rate, live birth rate across the age was higher. And then I also answer it this way, Madam, I'm doing going through an IVF. Before I embark onto IVF, suppose you fail, what am I going to discuss with you? And I tell them, well, I'm going to discuss PGTA. And that was, so do you want to do PGTA right here, irrespective of the age? If they say yes, I said, go ahead.
Fantastic. So it is very important that we send this message of time taken to pregnancy as one of the concept, because but time taken to pregnancy is taken very clearly in abroad. In India, the time taken to pregnancy is never coming to limelight and we never assess it. I think that will come as one of the parameter in the next era. Next 10 years, this will be the topic of discussion because everybody is in a hurry to get pregnant. So TTP, time taken to pregnancy, should be assessed, and I think it will be giving us more information.
Even today in our practice, we, from a clinical point of view, we want to give more pregnancy in the first cycle rather than they're getting in the third cycle.
Yeah. Fantastic. So very good.
Sir, one more question from me. Sir, for euploidy, what you are doing, like invasive method or by media, non-invasively you are doing PGTA?
No, NIPT is completely out, madam. We're not NIPT. Your non-invasive is completely out. We only do trophoectoderm biopsy.
Okay. Thank you.
Nobody should do NIPGT. Nobody.
Yeah,
nobody should.
that's all three societies have come to a conclusion that we are not going to do NIPGT in India.
Yeah. There is no point.
One last question. So in HRT cycle, we are seeing scan on day 9 and it is showing 7 mm endometrium. And again, we are calling the patient on day 12. It is showing it has reduced from 7 to 6.2. So what to do in the next cycle to prepare her endometrium?
Nice question, actually. And this could happen to anybody. A very easy answer could be this: an intra-observer difference, because you're using the same machine, but it's an intra-observer difference. One of the readings is wrong. What I would do, I will sensitize my patient that this is what has happened. I really don't know why this has happened. So let me do your estrogen progesterone values. Now the estrogen level comes less than 100 picograms. I said, well, let me take the estrogen more than that and look at the endometrium again. That is one. Second, I will just start on progesterone. I tell her, please take progesterone for 5 days and let me look at the endometrium after 5 days. If after 5 days the endometrium is 7 millimeter or more, I said, well, it decreased, but we can neglect that up and we can go ahead and transfer. So it's a completely individualized decision making. You'll have to do that up. But I do agree that can create a bit of confusion in everybody's mind.
As a team, we practice in our center. So how we can reduce the inter-observer error is, every time you take an image of the endometrium, take at least 3 images and take an average and then save the images. Save the images, because we don't sometimes save the images. So only when you save the images, if it happens again in your unit like this, you go and see the image and see what can be improved, whether that observer didn't measure correctly, or it can be contractions. It can be even myometrial waves which is causing this error. So I think patient we should not point out the finger on other person. Maybe they also measured correctly and we also measured correctly. I think that will also be helpful and it is not to be worried much by 7 and 6.2. Yes, as Dr. Sachin has told, it is okay to have 7 and 6.2. That much of 1 millimeter, 0.8 millimeters difference is permissible in a clinical setting. Yeah, thank you. I think it was a fantastic session. You can all post the questions in our Foxy group also. And it will be a recorded session which is available in YouTube. You can also watch if you have missed the initial part or later part. So thank you. Thank you, sir.
Thank you so much. Thank you.
Thank you.